class, we're going to discuss different theories of trauma and PTSD work and also some specific interventions within those theories. So, the first one we're going to look at is brief psychodynamic psychotherapy. So, you can recognize this from theories class as we've learned about the different psychoanalytic theories. And the focus of this treatment is looking at those early childhood traumatic experiences. And those experiences cause certain emotional conflicts within a client. And so, as we focus on that theory, the therapy, that we're going to look at how do we help clients move through that emotional conflict, resolving some of the internal conflict by going back and working through those early childhood traumatic events. The interventions in this theory involve talk therapy. So, as you can imagine, clients will go and retell the stories of those traumatic events. So, it's definitely a very left brain approach in terms of treatment models. However, the more clients share their stories, often what happens is there is a reduction in the emotional charge of those trauma memories. By the counselor witnessing these stories, there is validation for the client and empathy is conveyed. So there's a lot of transference work done within the psychodynamic theories, and this one is no exception. The focus as well in terms of interventions has to do with being aware of the defense mechanisms that the client may be utilizing to avoid pain and to self-protect. So therapists with this model have to be very aware of those defenses and utilize them in terms of working through some of the treatment. So clients may have some denial and minimization and repression of trauma and traumatic memories. And by talking through the things that are at the conscious level, the client then can start being more open to the reality that happened to them. Abreaction is a term that we use under this model, reliving the experience to release the suppressed emotion. So clients that have a strong emotional reaction in session as they're talking through the work is part of the whole intervention in the specific model. And it's a form of catharsis. So being able to release those emotions helps to resolve them. It's based on a dyadic developmental psychotherapy, so attachment theory is utilized as well within this model, and clients can then work through their attachment issues from those early attachments that may not have been formed well, or there may even be abuse. And by working with the therapeutic relationship and attachment, there can be significant healing there. The self-trauma model is another model within trauma therapy, and it's very similar to a person-centered approach, an Adlerian approach. The main principles of this theory are respect for the client, unconditional positive regard, and assumption of growth, that regardless of what the client has been through, that healing is possible, and that the client is an expert on what they need, and that they have internally the resources that they need to be able to thrive. So interventions would be providing a safe environment within therapy and providing support for the client in an unconditional, non-judgmental manner. Providing therapeutic feedback. So this would involve, as a client is sharing their story, just being able to reflect on the difficulty that they've been through, and also the amazing amount of strength and courage it's taken to work through some of the trauma. In addition, this self-trauma model can go into boundary work and help the client to move through some stuck stages, either developmentally or within relationships. And do some assertiveness training, learning to use their voice, to be more authentic to themselves, and to be an active participant in healthy relationships. So then the next theory that we're going to talk about is cognitive behavioral theory, which I know many of you are very familiar with from theories and skills class. So as we apply cognitive behavioral to a trauma model, we can look at two different aspects. The cognitive aspect will look at the thoughts and thought patterns that the client has and what distorted thinking may be causing some of the distress. And from a behavioral perspective, changes can be made to maladaptive coping skills and behaviors that may be producing undesirable results. So there's a lot of ego strengthening as interventions in terms of building up the ego, as well as cognitive restructuring. So identifying triggers and unhealthy thoughts and irrational thoughts and schema, and replacing those with something that is more advantageous for the client. There can be cognitive dissonance under CBT where trauma memories conflict with their current beliefs. There's a theory under the umbrella of CBT called World Assumptions Theory by Janoff Bowman, and there are three specific cognitive distortions identified there. Beliefs impacting whether the self is worthy, the world benevolent, and the world being meaningful. So trauma can have significant impact on schema that are related to these specific areas. So that is something that that CBT would focus on is what schema have been distorted as a result of the trauma, and what behaviors are may have been adaptive during the trauma, but at this point are causing some distress and dysfunction. So there are some additional CBT techniques for post-traumatic stress disorder, and I will list them here. A lot of these are included in your readings, and some of them we're going to go into further detail. So we discussed some cognitive therapy, we discussed behavioral, exposure therapy, which we will discuss, stress inoculation therapy, cognitive processing therapy, dialectic behavioral therapy, also known as DBT, and acceptance and commitment therapy. So before we get to those, I wanted to give some examples of specific interventions under the CBT umbrella. There are exercises involving safe place, both visualization and art therapy even can help with helping the clients to picture a safe place. There's also some containment exercises under CBT that help the client to contain the thoughts that are related to trauma, and when to open the box, if you will, in terms of processing through the thoughts and memories, and when to close the box and take a break. There's also specific CBT with children called TFCBT, so Trauma-Focused Cognitive Behavioral Therapy. And this utilizes CBT interventions, but it's within the context of a family unit. So both parents and children are involved in the therapy. And so this is specifically for children ages 3 to 18, and it can involve one parent or both. And at the same time that the child is receiving trauma treatment, the parents are also being taught parenting skills and better ways to help the child with their own therapy. Psychoeducation is a huge part of TFCBT, as are building up the different coping skills, relaxation exercises, and then doing sessions together with both parents and children to discuss the therapy, how it's going, to improve communication, and to just foster and enhance safety as well as developmental issues. There's also another approach for children called TBRI, which is Trust-Based Relational Intervention, and Karen Purvis was the founder of TBRI. And what I really like about this approach is that there's a focus on the attachment as a main part of the therapy. So it's it's attachment-based trauma-informed care. And again, it involves the family unit. So one of the therapies that was often used, but is not used quite as much anymore, is called prolonged exposure therapy. This is based on the idea of habituation, which meaning that the longer you expose the client to the actual feared stimuli, that over time the brain would decrease the emotional charge to this response. So it's a conditioned emotional response. So the clients will basically learn nothing bad is happening as a result of this stimuli, that the stimuli itself is benign, and that the amygdala and the alarm system in the brain, with habituation, can learn over time that it does not need to sound the full alarms in response to this trigger. So there is psychoeducation as a component of this as well. The exposure can either be imagery, so imaginal, where the client is in the therapist's office and imagining this, or it can be in vivo with some real life exposure. That systematic desensitization is included in this approach, to where there's gradual exposure to the stimuli. Now, and this approach does have some merit, and some people still use it. However, I warn that it is something where clients can definitely be re-traumatized, and so there are many other approaches that can promote safety probably better than this approach. There's also, even if they're not re-traumatized, there is a risk of just increasing the PTSD symptoms in this approach. I certainly would never use this approach with somebody with complex trauma. If they've had childhood developmental trauma, prolonged, repeated, that type of thing, I think that prolonged exposure is a very dangerous approach to use. So I wanted you aware of it, because there's other approaches such as cognitive processing theory that do include some exposure, but it's the prolonged exposure therapy that, in my opinion, is just not something that I would recommend. So moving on, though, to cognitive processing theory, this is a combination of both cognitive theory and some exposure. It's usually done within about 10 to 12 sessions with the client. So the target, is similar with cognitive theory, is that you want to change the faulty thoughts and beliefs that the client has developed about the trauma. So there are 4 steps under CBT. Number 1, psychoeducation about PTSD and trauma. Number 2, some gradual exposure, being paired with relaxation. And so working on triggers, and often using written accounts of the trauma to process, but it's not a requirement. But written accounts is definitely a common intervention under CBT. And then challenging the thought distortions and applying new thoughts and schema that would be healthier in terms of promoting wellness overall for the client. So I've included in the PowerPoint some resources if you'd like to get further training in CBT and just find out more information about it. So moving on to stress inoculation therapy, also known as SIT. So under this theory, the focus is on skill building. So many clients, especially ones that may have experienced developmental trauma, may come in with just a lack of skills in certain areas, and building up how to manage anger and strong emotions, boundaries in relationships, managing triggers and coping and relaxation exercises can really improve not only the client's ability to emotionally regulate, but also their confidence level, and improve their support systems as they maintain better boundaries and healthier relationships. So the intervention here would be Socratic dialogue between the therapist and client, open-ended questions, and again, just working on building back up those skills through role play, modeling, and other techniques. Acceptance and commitment therapy, known as ACT, This is a theory that I utilize not so much as a standalone theory, but as something that I incorporate when I'm doing CPT or some other of the modalities. Acceptance and commitment therapy makes room for the difficult trauma memories because it looks at um, this as a not something to be avoided, but instead something to be accepted as part of the life story. And so there's less rejection of self, I find, and self alienation when we use ACT with clients, and helping them to see that again, the trauma doesn't reflect who they are, but it's something that they've gone through, and their survival is to be integrated into their story. So it works with clients that have again some high avoidance, some control issues, that type of thing, and really practicing mindfulness is a key component and intervention of ACT. And doing some narrative work, normalization for the client, and accepting that reality again as part of their life story, and making whatever changes they need to in thoughts and behaviors to be authentic to themselves and to their story. Okay, moving right along to DBT. Again, this is under the umbrella of CBT. It combines CBT with radical acceptance, similar to that ACT. But the focus is on emotional distress, and it often includes people that are having some symptoms, possibly of personality disorders, difficulty with emotional regulation. And so instead of moving on to phase two trauma work, the DBT stays more in phase one, where you're again building up those skills of emotional regulation, grounding, mindfulness, stress management, boundaries, relationships, and the having an additional help with maybe clients needing more than just individual therapy. So there's also group work done in DBT, as well as telephone counseling, checking in with clients in between sessions. There's a whole consultation team behind a DBT approach that can be very helpful, especially for clients that found individual therapy to not be quite enough for them. Okay, and then finally, tonight we're going to talk about narrative exposure therapy. So, again, some of you are very familiar with Epstein and White's narrative theory. This is adopted from something that came out of military survivors, known as testimony therapy. So, clients would construct a life narrative, and I like to have clients do kind of an autobiography format here, where they are first titling what would be the title of their autobiography, and then how would they divide the chapters, what titles would they give to the chapters, and then filling in more of the details, first with facts, and then maybe some more emotion, and maybe some illustrations at some point as well. So again, there's the concept of habituation, that the more they tell their story, and the more they process these trauma memories, the more the emotional charge would decrease, and the danger reaction would decrease in the brain. As they construct these stories, they share them with the therapist, and the therapist in narrative exposure therapy again is playing a witnessing and supportive role to their life story. So those are some of the different theories. I know I went over them briefly. We'll definitely talk about them more in class. But as you approach clients and as you move on to do the case study, I want you to not just think about what interventions am I going to use, but I want you to think more broadly about what theory am I choosing, and how does the theory view the client? What assumptions are the theory making about dysfunction, about wellness, as well as about how to best treat the client. So look at theory as your roadmap, as the broad umbrella and try to focus in on maybe one or two theories that seem most interesting to you or the best fit for you, and maybe do some further reading on those as different ones pique your interest, and then we'll practice applying one or two to those as your case study. Okay, so I will talk to you more about this in our live class.